morning. The Disability Commission is now called to order. We do have a newly appointed member. She's not here yet. And congratulations, Connor. You have been reappointed, Connor Cummings. I'm going to ask my colleagues to go ahead and introduce themselves, and I will start to my far left with my colleague, Senator Hashmi.
Good morning. I'm Ghazala Hashmi, representing the 10th Senatorial District, which is Richmond City, Chesterfield, and Powhatan.
Good morning. I'm Delegate Philip Scott. I represent the 88th District, which has parts of Spotsylvania County, Stafford County, Fauquier County, and the city of Fredericksburg.
Good morning as well. I'm Otto Waxman. I'm the delegate representing the 75th District. That includes the counties of Sussex, Greensville, Brunswick, Southampton, cities of Emporia, Franklin City, and parts of Lunenburg.
Delegate Bobby Orrock, currently the 54th District, parts of Spotsylvania and parts of Caroline, and been serving on the commission since its inception.
Hello, everyone. I'm Connor Cummings, a self-advocate on a state and national level.
Thank you, Connor. I'm Senator Barbara Favola. I represent portions of Northern Virginia, which would include Arlington, Fairfax, and Loudoun, and I have served on the Disability Commission for about 10 years. So the issues before this commission are very important, and they're incredibly impactful to many Virginians, and each and every person in this room, in the audience, on the dais up here, each person is very committed to helping folks live as full and complete lives as possible. And we've just been joined by Delegate Hope. Would you like to introduce yourself?
Good morning. I'm Delegate Patrick Hope. I represent the 47th District of Arlington County. Pleasure to be here.
Okay, I will ask the clerk, do we have a quorum?
Madam Chair, we do have a quorum.
Okay, thank you. The first item on our agenda is a presentation by the Department of Rail and Public Transportation regarding transit equity and a modernization study. Jennifer DeBrule is our presenter, so welcome, Ms. DeBrule.
Good morning, Senator Favola and members of the Commission. I'm Jennifer DeBrule. I'm the Director of the Virginia Department of Rail and Public Transportation. Very pleased to be here today to present the outcomes of our transit equity and modernization study that we completed earlier this summer. Do you have my slides? Yeah. Got a few slides to pull up here. Thank you. So it's not working. We'll get started. Okay, great, thank you. So the Transit Equity and Modernization Study was commissioned by House Joint Resolution 542 that was patroned by Delegate McQuinn back in the 2021 General Assembly session. That legislation required us to complete a needs assessment focused on the equitable delivery of transit services and the modernization of transit across Virginia. There were two key deliverables for this study: an interim report with some preliminary findings and data analytics that was submitted at the end of 2021, and then the final report, which was a set of targeted recommendations and an action plan that was submitted to the General Assembly in August. The study itself had several transit technical topics in the transit realm that we had to look at. First being accessibility. We also looked at emerging technologies, system safety, the adequacy of infrastructure, electrification of our systems, and then engagement of our transit systems with the communities, their riders, and the governance of those systems. For the study process, we really broke it down into four parts. We started in the summer of 2021 with a very robust data collection effort, looking at existing conditions around the Commonwealth, industry best practices and peer research from around the country. And during that data collection phase, we also did had a number of opportunities for stakeholder input and review. The outcome of that phase of the study was a memo with the baseline conditions and the needs assessment. We took that data and moved into looking at the needs and really trying to identify opportunities that we had to move the needle here in the Commonwealth to make our transit systems better. We did that work by those technical areas, and we identified a slate of opportunities for each technical area. We had work groups, very robust work groups in each of those technical areas, and also engaged stakeholder input as we worked on that process. The result of that second phase was our interim study report that we submitted in December of 2021. Once that was completed, we turned to our action plan, and this is where we spent a fair amount of time brainstorming on how we could best realize our and really optimize those opportunities, evaluate different alternatives for implementation, and again, went out with a robust stakeholder input process, resulting in a detailed action plan that ended up being encapsulated in the final report that we submitted in August. In terms of public and stakeholder engagement, we had over 3,500 individual interactions with the public through the course of the study. This slide says we had one virtual public forum. We've since had a second virtual public forum upon the completion of the study with over 100 attendees. We also had a Transit Equity and Modernization Committee that was gathered. It was transit CEOs from around the state and our staff working on what things we could do in partnership to make our systems better. We had technical working groups. We had a very robust and active website with feedback from the community. We did questionnaires, surveys, did a fair amount of outreach electronically. Most of this study was done while we were still in the thick of the pandemic, and it was hard to gather people in person, so we had to be creative in how we engaged the public in the study. And one of the things that I will tell you I gained the most out of in terms of that public engagement is we used some really innovative technology to do focus groups. And we worked with the transit agencies to identify riders. We had 7 focus groups with 48 participants over a several-week period. And we were able to do those focus groups using technology so that we could kind of sit on the other side of a one-way mirror. So the focus group was meeting virtually through Zoom. They had a facilitator through Zoom. We were on the other side and could ask them questions through the facilitator. So they didn't see us. We didn't influence what they said. But it was a way for us to get the kind of information about our transit systems and how they function in a way we've never been able to do before. And so that was very valuable to us in terms of how we conducted the study and then where we went with the action plan. So I'm going to spend a few minutes talking about a few of the key findings. There are a lot more findings, but I really wanted to hit a finer point on some that I thought would resonate most with this group. First, and I think this will not come as a surprise, we found that many bus stops are poorly placed. They don't have good connections to sidewalks and are not ADA accessible. And this is a huge concern for us because if people can't safely access the transit systems, they can't access that mobility that is a lifeline to jobs, education, healthcare, and basic needs. And so that is something that was a very key concern that came out of the study. The basic transit infrastructure we see, generally speaking, around the state is inconsistent. Some places, particularly in our urban cores, we see more shelters, benches, lighting, concrete pads for bus stops. The more you get out into suburban communities, that is less frequent, and you often see a bus stop sign on the edge of the pavement without a place for people to wait for the bus. And so that is also something that is a great concern and we think affects accessibility of our systems for the public. We do have good availability of transit in Virginia. It's generally high, but we do have some gaps, and we have some tools in place to identify how best to address those gaps. Some new technologies that we're trying out that can provide service in a different way, not necessarily a fixed route bus, but in areas like Hanover County, where we have a private contract to do some on-demand transportation for seniors and individuals with disabilities. It's been very popular in that area that previously had no public transportation at all. We did also find that transit riders have, in many cases, limited opportunities to be part of the decision-making process and limited opportunities to have their voices heard as systems are deciding how to provide their services and how those decisions are made. And that's an area I think we can also affect some change through this study. Most transit agencies do not have rider advisory boards or committees. Some do, but that is something that we've seen is identified as a best practice and an opportunity for those transit agencies to hear the voices of their riders and their system users more frequently and more effectively. Transit is among the safest ways to travel once you get on that bus. Transit's generally very safe from an operational perspective, but there is room for improvement. We've seen over the past few years an increase in safety instances, not only for our transit riders, but for operators and transit system employees. We've seen a number of transit operator assaults, and that is an area of concern that even if it's not an actual safety concern, it does create a perception that safety is a concern. And for me, I think one of the things that I'm most concerned about is the safety of the user accessing the bus and the pedestrian access to the bus stops, crossing the roads. We've got to think about things more holistically in terms of the safety of our system. And so that's also something that we identified in the study. Finally, last point I'm going to make on study findings is, we had access to data, or we were able to use technology to get data in the study that we've never had access to before. And having more data that is more precise, more real time, enables us to make better informed decisions about how we allocate resources, how we prioritize projects. And so that's something that we've identified as an area that we can continue to do more work going forward to stay more active and aggressive in how these study findings are implemented. As I mentioned previously, the final report really is an action plan, and it is very graphic and very interactive in terms of what it looks like. And what's captured on the slide are just a few actions that are identified in the plan that I think might resonate with you this morning. A few things: developing technical guidance and policies on bus stop design and how those stops are implemented is something that we think we can do as an agency to help move the needle. We've identified some things from a regulatory perspective that really stand in the way of putting bus stops with shelters and amenities on state right-of-way that we're working through right now to make it easier for local governments and transit systems to provide those basic amenities with funding that we have available through the Commonwealth Mass Transit Fund. We also think we've got some opportunities to provide technical guidance or share best practices on how systems are monitoring their infrastructure and they're reporting to their boards and commissions on how to best meet the infrastructure needs and have those amenities in place at those bus stops. A good example of that is Greater Richmond Transit Company here in Richmond has a very aggressive plan to improve all of their stops with shelters and amenities over the next few years, and I think that's a best practice that we could see implemented around the state. We want to continue to identify areas with unmet needs where we can come up with a solution that is both effective and efficient in providing services for the communities that need them. We want to see more engagement of riders in the process and the ability of our transit systems to hear the voices of their users more frequently to help address their needs through their system planning and through their capital programming. We want to keep the dialogue going on safety and develop best practices for safety and how we can engage the community to do that. More aggressive public engagement and providing some more tools and a handbook to help our transit agencies be more inclusive in their public engagement at the local level, and then coming up with some qualitative and quantitative metrics to measure how reliable and efficient our transit service is, how effective it is at meeting the needs of their communities, and providing access to lifeline services. So an aggressive action plan. So moving forward, sorry.
I have a question.
Sure.
On your last item here, develop best practices for safety-related roles to create community partners. I would think you would want them to be multi-jurisdictional, local governments, and mutual bodies that receive transportation money.
Absolutely.
Can't just be the state.
Correct. And that goes right into my next slide. We have an action plan that is not just the state. DRPT will lead many of the actions that are listed in the final report, but we can't lead all of them. It takes coordination, and I really do see one of our key roles as an agency to be a convener and a thought leader and to bring the parties together to have that dialogue. We can't I don't run a bus, I don't place a bus stop, but we help make that happen by having the dialogue with our partners. So local transit agencies, state agencies, advocacy organizations, we've got a very broad reach through the Commonwealth. And to do the things that are outlined in this study, we will need to work with all of those partners in order to be successful. Our next steps, we've submitted the final report. In no way is our job done there. This is something that we perceive to be a living document. It's a conversation that we want to continue to have moving forward in working with the transit agencies and local government to implement those near-term actions that are identified in the action plan, work on funding opportunities, not just with the tools that we have available with state funding, but with the incredible federal investment through the Infrastructure Investment and Jobs Act. We want to look for opportunities to partner, be creative, think outside the box to better meet the needs of our communities. We've had great support from our local and regional partners throughout the study process. This particular study is the first of its kind in the nation to be done. So we will be on the circuit telling our story over the next year or so, and we're committed to continuing to monitor and evaluate our process going forward. And with that, I appreciate the opportunity to be here today and talk about the study, and I'm happy to answer any questions.
Thank you, and thank you for your hard work in pulling this report together. I'll ask my colleagues if you have any questions for our presenter.
Yes, ma'am. Yes, Chairman.
Oh,
Madam
yes,
Chairman.
Delegate Orrock.
Yeah, Mr. Brule, good morning. Not so much a question, but just a potential as you're looking at thinking outside the box. It has always struck me as curious that we've got, every county has a transportation fleet the kids typically call a cheese wagon. And they're incredibly underutilized, obviously, on weekends. And several years back, I put in legislation trying to facilitate building a cooperative arrangement between local governments using those buses in non-school hour times. I just throw that out as a suggestion to try and reach out in that population area for a pilot program. There may be some liability issues involved that may take a legislative fix in order to facilitate it. But I think, we've got the handicapped transportation buses there. We just need to facilitate their use beyond the normal school hours, since they're already paid for by the taxpayers, and just try and find a way to better, more efficiently use that resource. So I just throw that out as a thought.
Thank you. We'll definitely look into that.
Any other comments or questions? Oh, yes, Delegate Hope.
Thank you, Madam Chair, and thank you for this excellent report. I'm glad that we're doing this. And this is one of those things where we just don't want to have a report that sits on a shelf and gathers dust. I want to make sure that we have an implementation plan. Maybe it's a 1-year, 2-year, 3-year, 5-year, 10-year plan on ensuring that this is continuously be updated, but also have a plan to implement its recommendations.
Yes, so that was that. I've spent most of my career in infrastructure planning and infrastructure delivery, and I've seen a lot of plans sit on a shelf, and I am definitely not wanting to see this one sit on a shelf. So the way it was structured, it wasn't just a study that outlined a number of problems and some ideas to solve them. What I wanted the end product to be was that action plan with those time frames, short-term, mid-term, long-term, for us to have a target that we work towards. And so it is my commitment to you that we are working towards that, and we're going to keep working towards that going forward. I do think that we will periodically refresh this, and the way we've published it gives us the ability to make it a living document, and so we can track not only our successes and what we've been able to implement, but we can make changes as we learn and grow from this process.
I guess in conclusion, as you proceed to implement your action plan, of course, in a multi-jurisdictional way, if you find that there may be legislative fixes or perhaps incentives that the General Assembly can move forward with to help with the implementation, that would be worth acknowledging what those might be and letting us know. So periodically reporting back to the General Assembly is probably a good thing as well.
Absolutely. Thank you.
Thank you. Thank you for your presentation. Okay, colleagues, we're going to move to item 3 on our agenda, which is presentation of report This was regarding changing the medically need spend down for Medicaid programs. The intent was to remove barriers to independence. Kelly Pauley was with us at our last meeting. She is the eligibility enrollment manager at DMAS. We charged Ms. Pauley with actually evaluating a bill from Delegate Shin regarding the proposal to allow for medically needy spend down. Ms. Pauley, are you on the Zoom?
Ms. Paul, you need to unmute.
Okay, can you hear me now?
Yes, we can hear you.
Okay, thank you. And I have Brian McCormick here with me. He's our Director of Legislative and Intergovernmental Affairs. So I appreciate the opportunity to come back. You did have some questions last time, so we attempted to answer those. Let me see if I can get the slides going. Can you see the show now?
We can see you. You have
can see me.
a nice backdrop, which is lovely, but we can't see the slides for your presentation. So perhaps
All right.
if you give us a moment, we can work on that technical piece.
Ask the person, do I need to stop my video in order to show it, or?
Give me 1 second.
Okay.
I'm sure we can figure this out.
You should be able to show it now.
Okay. I know, let me try one more thing.
We can now see your slides. Okay.
Okay, good. All right, let me see if I start the slideshow, it will actually move. Okay, now do you see the slide?
Yes.
Oh.
Yep.
And
We're on
and-
slide 2.
okay, great.
Okay.
All right. So when I was here back in September, we talked about the report that was required under SB 213, and also about the issues that HG 85 was asking to look at. And some of the recommendations that we discussed were raising the personal maintenance allowance to 200% of the SSI amount, or 250%. And the reason that we talked about those amounts and not the maximum amount was that those were the amounts that we had looked at the costs for previously. The maximum amount is 300% of SSI. We had also talked about implementing an excess housing expense allowance for members in areas of the state with higher housing costs, allowing a temporary personal maintenance allowance while people were in an institution, and implementing the medically needy option for the DD waivers. Delegate Shin's proposal requests that we study the feasibility of implementing the spin down provision for these waivers. Currently, the CCC Plus waiver does have the option of allowing a spin down, but the DD waivers do not. And if you remember, the spin down option is where if the person's income is higher than the medically needy limit that I'll show you again later, then they could be eligible for Medicaid if their medical expenses were high enough that their countable income would be down below that limit. And so we had already recommended implementing the medically needy spin down for the DD waivers. As we discussed last time, there's no fiscal impact to allowing the medically needy option for these people because the slots are capped So unless you add more slots to the amount of waivers that we're allowed to give, then it wouldn't change the expenditures. There would be no new enrollment because of that. I did also send a question to CMS, which is the Center for Medicaid and Medicare Services, regarding whether we can expand our definition of medical and remedial expenses. In the law, it just says we can only allow medical and remedial expenses from income or for the patient pay calculation. And so I added in that email that I sent to CMS the list of expenses that are allowed by special needs trusts and qualified disability expenses for the ABLE account. And so they are considering that, and they will let us know whether we have any discretion to add more expenses to that list. So the second question that I was asked to get the information for was how much would it cost to just do away with the wait list? I didn't realize that this was a difficult question, but it is. So I was asked to explain why it was difficult. The number of people on the wait list changes daily to weekly. The wait list captures the level of priority, not the waiver services needed, and the waiver needs of the individual may change as they are on the wait list. What they mean by priority is that does somebody need to, are they going to need services in the next 5 years? Do they need services right now? Or is there something in between? So like a high priority person might be somebody whose caregiver has died, for instance. And so they no longer have a secure living environment, or that their needs are very great. Somebody with a lower priority would be somebody who is in a stable situation right now, but could benefit from the services. And so they were telling me that right now on the wait list, so people don't go on the wait list just for a particular waiver. They go on the wait list because they qualify to be served, and then they prioritize them. And this is the Department of Behavioral Health. They prioritize them based on how great their need is. And so you can see right now, well, at the end of September, there were over 3,000 people who were priority one, who definitely needed services right now. And then 6,000 that would need it soon, and 4,000 that are on this wait list, but probably don't need the services immediately. So that's a lot of people. And these are the slots right now that are being utilized. BI means Building Independence Waiver. Family and Individual Support Waiver is the orange one, and then the Community Living Waiver is the gray one. The slots are apportioned by behavioral health, and they determine who moves into those slots based on their criteria of whose need is the highest. And when someone leaves services, either they die or they don't need those services anymore, or they move out of state, then the Department of Behavioral Health and the Community Services Board reapportion the services to the next person that needs it in that area where they could access the services. So it is a little bit more complicated.
Madam Chairman.
Yes, Delegate Orrock.
And Ms. Paula, I appreciate the challenges you're having with coming up with numbers. And I think this was based on a question I had asked. So I'm going to try and rephrase it and ask for a response just in writing. We don't have to come back for a public presentation. Mm-hmm. Because if we put in a bill to reduce the wait list by 2,000 slots, then y'all would have to come up with a fiscal impact statement as to what that would be. And so I think the question I asked last time was probably too broad, and rather, if we're going to do this, we're going to have to do it incrementally. And looking from the numbers you provided this morning, we've got a wait list of 14,000 plus. So if we were to propose the legislation for the coming session that were on an ongoing basis, hopefully to increase the number of slots by 2,000 annually. If you at some near term could tell us, quantify how much that would cost within our budget allocation, I think that's something possibly under the constraints and the complexities more doable. Would that be accurate?
I would certainly take that back and ask the budget people to look at that again. Now, on the slide that I have up now, they did give me some rough estimates. After all those disclaimers, then they gave me some rough estimates. Something that I wasn't fully aware of is that even though almost everyone who's on Medicaid in Virginia is in managed care, some services are carved out, and that means they're billed separately, because I didn't understand why the different waivers had such different costs. But you can see that they're estimating, like for next year, that somebody who is on the community living waiver, it would cost $116,000. And so in order to get an estimate, I mean, I guess they would, average it in some way to try to figure out about how much it would cost. But this slide is their estimate. And so I guess when you were looking at it, you might want to consider which waivers you wanted to provide slots for, because they don't all cost the same.
Right.
But yes, we'll certainly take that back.
And Madam Chairman.
Follow up, Mr. Auerbach, Delegate Auerbach.
If I may, yeah, because Ms. Pauly, long and short, what I'm trying to get at is the fact that from your wait list, we're seeing that increasing every week during the month of September. The problem is getting ever bigger. If we retain the status quo, that elephant gets bigger every week. And we have more and more folks that are not being served. And so my objective here is let's try and find a path going forward where we can start reducing the wait list. But in order to go forward with that, we've got to know how much money we're talking about in some fashion. And so we can kind of do this one of two ways in my mind. We can do it on the front end. So we as a commission, before we introduce legislation, know how possible it may be versus put in a bill. And then we get the fiscal impact statement and it's a budget buster and we haven't made any progress. So that's my objective. If you could just assist us. And I'm just using $2,000. If y'all could, 2,000 slots. Y'all could spread that out. It would be even better if we were even just reducing it 100 slots a year, up to 2,000, so that we know what may be doable. And we as a commission and as a body politic come up with, we know we can't solve the problem overnight, but we're developing a plan whereby going forward, we're going to factor this into future budgets.
Right.
I would think the Finance Committee is probably evaluating this very carefully as well.
Right. And I'll certainly, take that request back. We want to be as helpful as we can to get people to have the services that they need.
And
Absolutely.
we appreciate that. Okay.
Okay. Another question that I was asked was, how would we raise the personal maintenance allowance by different income limits for different localities? Currently, we use 3 locality groups, and this is just a little history about how that was determined. But you could enact legislation to change the groupings or increase the limits or whatever you wanted to do. What the federal government says is that we just have to have a reason. We have to have justification for what our different limits are. And so we could certainly justify different ones based on cost of living if we tried to. This is the current medically needy spend down amounts in the different groups. So you can see that the monthly limit is super low. Mm-hmm. And so what that means is you would have to have medical expenses that would cover all your income over that amount. So you don't have to have paid them, but you have to have incurred them. So it's not easy to meet a spend down unless you have really big medical bills. but it would be another option for people to spend down to be eligible if they did need a lot of medical support.
Ms. Pauley, we have another, we have another question on Delegate
Yes.
Orrock.
Madam Chairman, the coffee's working. I'm quite alert this morning. Thank you. On question 3, if y'all could hear again, and doesn't have to come back before us, but just provide us the information in writing at some future point. If y'all have suggestions as it relates to, are the 3 locality groupings adequate? Are there better ways more efficiently to address that within the resources we have? You say that we could enact legislation. We need y'all's expertise in that area as to how we could most effectively do that, please.
Okay.
Well, I guess your workload's growing as each slide progresses. Go ahead, Ms. Pauley. You can resume.
I'm sorry. I was just writing it down.
Oh,
Okay. We also had some questions about what had other states done. And so some of our policy people here did some research and found a July 2022 study, which was very helpful because it told us what the rest of the state's personal maintenance allowances are. And for people who were in a facility, in a nursing facility, the average is $50 a month. Ours is the 4th lowest amount, so that does seem very low. I know in the past this has come up as a proposal to raise the personal needs allowance for people in facilities, and ours is very low compared to other states. Also, for people who are in the community, I was surprised to see that a lot of states, most of the states, have the maximum, which is that 300% of SSI amount. That means that people who are in the community keep that amount for their rent, their living expenses, and then any income they have over that amount, they have to pay to help with their cost of care. Now, the amounts ranged from $72 a month to the maximum, but we had the 13th lowest amount at $1,388 a month. 9 states reported that they varied the amount by the waiver program, which I didn't realize that you could do, and 6 states did not report a maintenance needs allowance at all, which seems unlikely because how could people live in the community if they're not allowed to have any income to cover it? But anyway, that's what that study found. States.
Quick follow-up on that.
Sure.
Regarding the personal maintenance allowance, was there any fiscal impact on that? I would
There
think
is a
not.
fiscal.
Go ahead.
There is a fiscal impact in that any money that we allow the person to keep means that that's less money going to help pay for their cost of care. So they have a responsibility to help pay for their medical care if they have enough money to do that. So if we allow them a higher maintenance allowance, then less money goes to the program to pay for their cost of care. So any change that you make has an impact. It's just that some are a higher impact than others.
And this is a very different concept than the spend down, the
Yes,
medically
it
needy
is.
spend down. I just want to make sure commissioners understand that they're 2 entirely different concepts.
Yes, they are. They're totally different. The spend down option is just not available for that particular waiver, but other waivers and other people in the state can use that option if they have very high medical bills that they would incur every month. For instance, if they've had a transplant and so their medication bills are very high every month, then they can provide those bills and we can see that they would incur bills more than their income over a period of time. And if that's true, then we can go ahead and put them on Medicaid because we know they're going to incur medical expenses. But once they were on Medicaid, we would pay for their bills for the rest of that period of time. But the personal maintenance allowance is something that people are allowed to keep in order to pay their living expenses. So this person living in the community, right now, we allow them to keep $1,388. That's what they have to pay their rent out of, pay for food, and any other expenses other than medical expenses. And then we cover them on Medicaid for all their medical, personal care, medications, things like that.
Thank you.
Okay, were there any other questions?
No, go ahead.
Okay.
You can proceed.
Okay, so in other states, they base their personal needs allowance on other factors like cost of living increases. Some of them, I think, have it set up so that it does change periodically instead of having to go through this process every time, which makes sense because inflation, does go up. Different living arrangements, they allow different amounts. Florida, for nursing facility people, has raised it up to $130 a month in 2018, and it changed from 35 to 105 to 130. Now, obviously, if you're in a facility, you don't have as many expenses, but you have some. They don't cover everything. They cover your food and your room and board, but they don't cover haircuts or anything recreational, cable, phone, unless, you have other expenses that you could need money for. Another question was, how have other states implemented a medical spend down for DD waiver recipients? In some other states, these people are allowed to have medically needy spend down. So we can implement a spend down for anybody that we want to. We have to, for instance, if we were to change those limits, the ABD limits, we would have to allow that change for everybody who is on a spend down. So it wouldn't just be for the DD waiver people or for long-term care people. It would be for anybody who met a group that medically needy spend down applied to and was eligible for that to be looked at. Now, down here, it talks about that an individual applying for waiver services can't project their medical expenses. Right now, we allow people who are in a facility, we project their medical expenses. And so we can approve them if we know that their expenses are going to be more than their income. And people who are at home don't have that option. Now, the CMS is considering changing that. And so if they do change that, that would be really good for people who were trying to get care at home, because then we would be able to estimate what their bill was going to be and go ahead and put them on if we could see that their expenses were going to exceed their income. In some states, in Minnesota, yes, they have to actually pay the spend down amount before they can be eligible. If your spend down amount is really high, this could be pretty difficult, but that is another option, is that in Minnesota, they pay their spend down amount directly to the Department of Human Services the month prior. And then if they don't exceed that amount in expenses, they get some money back. This seems administratively challenging, but that's what they do. And so that's what we had found so far. We can certainly take your other questions back and send you back some more information.
Thank you, Ms. Polly. I will ask my colleagues if they have some questions. Yes, Ms. Lawfer, Commissioner Lawfer.
Thank you. I was speaking with recipients in Louisa County, and the personal maintenance they are allowed every month is only $40, which means haircuts, telephone, all of these things. Some of them have to save up for several months before they can even get a haircut. I just want to mention this to say how low that amount actually is. Thank you.
Thank you. I had a bill to actually increase the personal maintenance allowance, and the Finance Committee did not act on it. So, but the question that precipitated this presentation was the bill that would allow for medically needy spend down for individuals on the developmental disability waiver. And the recommendation that we got back is there would not be a fiscal impact. So this committee actually is tasked with providing a report to the respective General Assembly committees, which I will ask staff to write a letter and include the presentation that we just heard that will constitute our report. But I would like to have feedback on the recommendation of permitting a medically needy spend down for those on the developmental disability waiver. What our inclination is with that recommendation. Do we want to move forward with it and make that as a legislative recommendation, which would then get into the whole legislative process? It would probably be budget language is what I'm thinking, and it may also require authorizing language. Okay, motion is before us that the committee recommend that we have a medically needy spend down for those on the developmental disability waiver. All those in favor of that motion signify by saying aye. Aye. Anybody opposed? Okay, very good. That passed unanimously. And I will ask staff, I guess, Trevor, it might fall to you, to prepare a report under my signature from this committee for that recommendation to go to the respective General Assembly committees. Thank you. And we will be in touch in terms of who will be carrying the legislation. Thank you. Let's move on to item 4, which actually, the last meeting I had asked staff with the permission of the commission to actually present a proposal on removing the phrase handicap and handicapped from the Code of Virginia. So, Mr. Bremer, thank you.
Thank you, Madam Chair, members of the commission, for the opportunity to present my bill draft this morning. It is in your packets. It's lengthy, around 100 pages. I think my explanation can be fairly straightforward and brief, and I just have a few slides for you to assist in that. So just as a reminder, the task that you requested at the last meeting was to first identify all instances of the terms handicap, handicapped, and similar variations in the Code of Virginia, and then to draft legislation that incorporates suitable alternative terminology. So we looked at the scope of the problem and found 71 instances of the term handicap, handicapped, or similar variations across 21 different titles of the Code of Virginia. For those not familiar, that's just kind of a division based on a broad subject matter area. So fairly dispersed usage of this term in the Code of Virginia. In terms of our recommendation for replacement, we recommend replacing handicap with disability as the normative alternative. Some of the supporting sources we looked at for that were the names of and terminology used by public and private advocacy organizations in the Commonwealth. So organizations like the Virginia Board for People with Disabilities, the Disability Law Center, you can kind of see it right in their names even. We looked at the whole Code of Virginia and found well over 1,000 instances of the term disability throughout the code. Wanted to highlight specifically the Virginians with Disabilities Act. 1985 was kind of a watershed year here where the General Assembly actually created a whole title devoted to individuals with disabilities and uses that terminology consistently throughout that title. Yes.
Yeah, Madam Chairman.
Yes, Delegate Orrock.
And I understand everything you've just explained. This goes back to many years ago when I became chairman. I asked that we consider addressing the title disability. Right. And like you said, this goes back in the mid-'80s. And my point being, my experiences and observations is most individuals we say are disabled are not per se, but are rather very challenged or impaired. But they can typically do what everyone else can do. They may just have to find other means or assistance or whatever. To my point then being, was consideration given to using the term impairment versus disability? And that's also consistent with what visually and hearing typically use that term. They're impaired but not disabled.
Right. Yeah. Thank you, Madam Chair and Delegate Orick. I did consider that, and I think you'll see on a later slide that in the context of vision, that's certainly the preferred term. What I just kind of found in the literature was overall disability is probably still preferred because of its descriptive accuracy. And for that reason, it's seen as sort of a neutral term. Definitely considered other terms like impairment, but there isn't as much consensus around a term like that, it seems. Yeah.
Just a comment, and perhaps you may want to comment as well, Mr. Brimmer. We want our programs using phrases that would be respected by federal grant makers. So we don't want to put any of our programs at risk of losing federal grant dollars. And I'm sure you considered that in your review.
Yes, Madam Chair. And I think simply removing the term handicapped would not affect any
And
any of
using
that.
the term disabled would be in line with sort of the federal nomenclature and federally accepted nomenclature.
Yeah, and again, on a later slide, I think you'll see in a second, there are some federal laws that still use the term handicapped. That said, there have been efforts on the federal level as well to change that to disability, just because of the obsolescence of the term. So I don't believe that we're jeopardizing anything by it.
Okay, I'm glad to see the federal government's moving in the more positive direction.
Yeah.
Okay, we'll stop talking and let you go through
That's
your
okay.
presentation.
Happy to answer any questions you have at any time. So yeah, as I was just saying, so on the federal level, handicap was much more common before around 1990. And then in 1990, you had the Americans with Disability Act passed, and then the Education for All Handicapped Children Act reauthorized as the Individuals with Disabilities Education Act. So watershed there being around 1990. So it's a several decade trend here towards the use of disability.
Thank you.
And finally, just a couple of caveats and clarifications. This just came up, but in the context of blindness and vision, the commonly used and preferred term is vision impaired. So I made 5 changes in conformity with that convention. So I did use impaired there because that's the preferred term for vision. And then 4 instances of handicapped had to be preserved in the code. 3 references to the Federal Voting Accessibility for the Elderly and Handicapped Act. As I just mentioned, there have been efforts to change that act to use disability instead, but they just haven't been successful yet. But we're at the mercy of the federal government there, so we have to keep that reference accurate in our code until it is changed. And then 1 reference in the Children's Services Act to child placements previously funded through the Interagency Assistance Fund for non-educational placements for handicapped children. Again, this was a former agreement, but there's not much we can do to change the name of it now because that's how it existed back when it was in effect. So it sort of just needs to stay as a relic in the code, unfortunately. So 4 places where we have to keep handicap, but again, we recommend the other 71 instances can be changed, as I mentioned in my presentation. And that's all I have. Happy to answer any more questions.
Thank you. I will ask my colleagues if they have a question. Delegate Hope.
So just a statement, and thank you, Ryan, for this. I mean, obviously it's very important we get this right. Virginia has always led the way when it comes to people with disabilities. 1990 was the Americans with Disabilities Act, but 5 years before that was Virginians with Disabilities Act. So we led the way and was the model that the feds used. And so it's really important that we're getting this right. I think we've got consensus here on the commission that we need to change the terminology. There's two ways that we can go about this. We can put out a bill and let people react, or we can listen to people and write a bill according to what the stakeholders would prefer to hear, because I don't think we want to do this exercise every year. So we chose to do the former, and that's fine to do that. I think it's super important before we come to any agreement here that we hear from all stakeholders as in terms of, to Chairman Orwalk's point, Chairman from HWI, not this commission, of course, but that maybe there's a different terminology that's better. I also want to know what other states are doing as well, too. I do get your caveat, and that makes perfect sense when it comes to referencing federal legislation. We have to be consistent with federal terminology. However, if there are other instances, and you pointed out to 71 of them, if it's more appropriate to use another word, I think we should consider doing that. Again, I do want to hear from stakeholders. I think that's the most important part of this exercise.
Well, Delegate Hope, you sort of took the words out of my mouth. We're not going to act on this recommendation today. We do have 13 individuals, I believe, last time I checked, in the waiting room for public comment. We may have individuals right here in the audience wishing to comment on this proposal. We can act on this in November. We will have a November meeting. So if this concludes your presentation, then I'm going to move to public comment at this time. And of course, public comment can be on any issue. You're not limited to just commenting on the nomenclature change that's being presented. But for those of you who do want to comment, this would be the time. And we will also have this on our agenda in November. But my expectation is that we would make a recommendation in November on how we should move forward. So I would ask individuals to send written comments to the committee between now and our November meeting, which I don't know when that will be, but I suspect it'll be 3 weeks from today. And then, of course, we will have the benefit of as many informed stakeholders as we can identify. I will also ask staff to send out our proposal to stakeholders that we know are interested in this area. I know the Disability Law Center is very interested. Colleen Miller is the executive director there, and I'm sure her group is looking at it. Okay, without further ado.
Thank you, Madam Chair. And I'll just mention for people behind me and maybe on the Zoom listening that the bill draft is posted on the commission's website, which is at the top of the agenda. So it's out there for anyone who wants to see it right now.
I think that's really important, and I think there's value of having an item out there where people can respond to it. So, and thank you for following our direction.
Thank you.
Okay, this brings us to public comment. I first will take speakers who are here in the audience. I will ask individuals to keep their comments to 3 minutes or less. And we are, of course, interested in whatever somebody might want to share with us.
Madam Chair, if you are in the audience and you would like to speak, please make your way to the podium and form a line behind whomever is speaking. And if you are online and you wish to speak virtually, please raise your hand electronically. You'll have a few minutes to do that. And we are going to have one round of that. So if you are in Zoom land and would like to speak, please raise your hand electronically. Thank you.
Thank you. Yes, ma'am.
Good morning. My name is Maureen Hollowell, and I'm with the Virginia Association of Centers for Independent Living. Assisted suicide has been addressed during recent sessions of the General Assembly. Assisted suicide is often referred to as death with dignity. There's nothing dignified about assisting someone to die rather than supporting them to live with needed medical, physical, and emotional support. Coercion and fraud are real possibilities in circumstances in which others may believe that death is more acceptable than living with a health care condition or disability. Some people with severe disabilities are made to feel that their lives are a burden, or that others make them feel uncomfortable with certain functions that must be performed for them to live. These attitudes can result in inadequate care and diminished expectations. You may have heard people say, "I could never live like that." Do they say that because they do not believe it is dignified to live with a disability, or they believe that they wouldn't be supported by others to live with their disability? We must not allow such a simple but dangerous statement as "I could never live like that" to justify assisted suicide. Once a person actually experiences a severe disability and receives the needed supports, their outlook may change. It often does. And they experience disability differently than they may have initially anticipated. People with disabilities live worthwhile lives. More people with disabilities could live dignified lives with adequate support. Legalizing assisted suicide turns back the progress made to understand and support our needs. Our focus must remain on improving, not ending, the lives of people with disabilities. Just this year, we're seeing more and more people with disabilities struggle to receive the basic support that they need, such as personal care in their homes, to remain out of nursing facilities and to remain employed. We have got to address the issue of the severe shortage that the Commonwealth has now, not is facing, but has now in regards to personal care assistance. Thank you.
Thank you.
Madam Chair, members of the Commission, I'm Dennis Finley. I'm the parent of a young adult with a disability. The larger question that I've been working on the last couple of years has to do with impediments to employment for those who are disabled. It was during the SB 213 study group process that the medically needy spend down was proposed as a solution, but the problem is bigger. So what I took away from the DMAS presentation, one was they're waiting to see from CMS what their response would be to expanding to the definition of what can be included in a medically needy spend down or other remedial expenses. But what they did not report on, the larger question, what have other states done to remove barriers and impediments to employment for the individuals that we're talking about on have Medicaid waivers that are DD. We did not hear that. And I've heard from my FOIA request from 3.5 years ago that DMAS came back to me and said, we know other states have addressed this problem and have solutions, but I've yet to hear what those are. And I just want to remind why we're here. Addressing the issue of Medicaid income barriers for meaningful life employment for my son and others, and it includes veterans as well. My son is profoundly disabled and lives in a group home. This is also an issue of someone who is profoundly a person with hopes, dreams, desires, and is trying mightily to play this thing we call life with the hand of cards he was dealt, a hand of cards that none of us in this room would ever want to have dealt to us. My son certainly wants to have a job, to be around people, to have purpose, to matter, to have joy, and as close as is possible for him to be like everyone else. That's all he wants. He doesn't want to be in a day program for the next 50 years of his life, doing puzzles, watching movies, and going to the park and doing nothing. No one is going to be on Medicaid longer because of this, because people like my son have been disabled since birth and will be on Medicaid the rest of their lives. And as was reported, since Medicaid-funded waiver slots are strictly controlled by the General Assembly, they decide how many slots there will be. We also understand that the whole concept behind the medically needy spend down or removing the impediments to barriers, this is all a calculation. It does not cost the state any money. Thank you very much.
Madam Chair?
Delegate Hope.
Just to you, Madam Chair, can we make sure, because that was something that was lost in the presentation from DMAS that I really wanted to learn more about, is that aspect of people being able to
To work.
work, continue to work and not lose their benefits. And so. if
Perhaps we could have a
if we could-
follow-up
If we can ask
presentation.
DMAS to give us that information, because that's an aspect of it that I really want to understand more. And it was
Yes.
really lost on me with that presentation.
Thank you, and we will continue to have presentations on this topic, not just written reports. So I will write that down. One of the things we will do at our November meeting is decide our work plan going forward. So I've got that down.
Madam Chair, I just wanted to mention again that if anyone is in the Zoom room and would like to speak, you need to raise your hand electronically. Thank you very much.
Yes, go ahead.
Hi, I'm Donna Burnett, and I'm here again representing my son, Brett Carroll. I shared his story last month. I want to thank you for moving forward with the medically needy spend down, but ask that we continue to look at more options, allowing those waivers to work best. I guess the key word is more options. And I say that, could you also add an hearing from Medicaid has to say about expanding the definition or language regarding medical and disability-related expenses? Are you separating them too much? Should it be broader terminology? I mean, it encompasses the whole life, and when you divide what is medical versus what is needed for disability-related expenses, we believe that those definitions can be expanded to include more comprehensively what our children need. And I just thank you. I'm thrilled that you're moving forward with the recommendation.
Thank you.
Hello, everyone. My name is Catherine Olson, and I represent the Alliance of Virginia. And I just wanted to thank you guys for using the word disabilities, and I prefer it over handicapped and vision impaired. And I just wanted to thank you for helping us with that word, because it means a lot to me, and it means a lot to everybody else with intellectual and developmental disabilities. And I thank you for this time. You guys have a wonderful day.
Thank you. Thank you.
Hi. Tanya Milling, Executive Director at the ARC of Virginia. I wanted to echo the comments before, so I can be super brief, that on the medically needy spend down, it sounds like, as well as Delegate Hope, that there's more to look at. And so we're glad there's continued conversation. And the ARC's actually working with DD Coalition partners to convene a conversation with the subject matter experts so that all of our organizations can also be on the same page about coming up with a solution that actually solves for the most people. And I think that's the key here. And I was also holding the spot in line for Brittany. Brittany, you don't have to go around, honey. That was my intention of doing it this way. But I would have Teresa go ahead, and I'll help Brittany in line here if that's okay.
Okay, Teresa, you may come forward, and then Brittany will be next.
Thank you so much. My name is Teresa Champion. I'm with the Virginia Autism Project. Good morning.
Good morning.
I'm here to talk about the issue of removing those barriers to meaningful employment. And the Delegate Hope hit it exactly. To be able to continue to work and not lose benefits. People are concerned that if we do this, that people are going to stay on Medicaid longer. Well, that's just not the case. And I recently served on a group called the Agents of Change for ECNV. And the discussion was about fear of losing benefits. That is a barrier to them to be able to go to work. So if you don't remove those barriers, then they won't be able to work. And so you've defeated your whole purpose. People want to work, and many can. My son can't, but you need to encourage the population of people with disabilities who want to work to be able to work. For example, expanding, like Donna said, the terminology. that broader terminology. Think about it a minute. You heard the transit report talk about there's really no ADA access for a lot of these locations for transit. So we're forcing people, because we're not providing them ADA accessible access, to take Uber or a cab or have someone drive them. Well, those are increased expenses. Why don't we, because of their disability, they're not able to access public transit that might be more financially accessible to them. So why don't we expand that definition so that that could be something that could be deducted? So if we don't make it more accessible for them, then people won't be able to work. I also sent you an email about a New York Times article. And that had a discussion of the lack of medical care for people with disabilities. Doctors, when given anonymity, admit that they do not want to care for people with disabilities. I ask that you look at and educate yourself about PANDAS PANS, because we have an advisory council in Virginia about this disability, and there is about this diagnosis. It's a medical diagnosis that presents with behaviors. And there are very few doctors willing to treat this, among other issues. So that's a broader question I asked the Disability Commission to look at.
Teresa, you have about 10 seconds left. So.
And also to talk to people who are not your constituents. We need more time. Thank you.
Thank you.
Hello, my
Hello.
name is Brittany Lee. I'm from the Alliance, and I prefer the word disability over handicap because I do have a disability. Handicap make me feel like I cannot do. And I hope you guys understand that because we are capable, very much capable. We are like everyone else. So why can't we use the word disability? Thank you for your time and have a great day.
Thank you, Brittany. You have a good day as well. We appreciate your efforts to come here and your comments. Thank you.
Good morning, Madam Chair,
Good morning.
members of the Commission. I'm Sarah Taylor with the City of Alexandria. This is an issue that we've been working on for several years. Our Human Rights Commission brought it to my attention, and we're grateful to y'all for your consideration of changing the word handicapped in code. We know that changing these words have meaning, and that it's more than just a kindness to people to make this choice. It really is an opportunity to change the lexicon, change the way this word is used, whether it's in schools, in the media, in our own dialogue here in the General Assembly. So we're grateful to you for your consideration of it. And in looking at the draft, the one thing I would note is that looking for opportunities to use people first language when we're talking about people with disabilities, just as it's called the Virginia Board for People with Disabilities, looking for opportunities in the draft to use that same people first language, people with disabilities, individuals with disabilities, because it's about the people. And so looking for opportunities to use that people, person first language in the draft is something that we would recommend. So we're grateful for your consideration and thankful for your work.
Thank you, Ms. Taylor. Sure.
Hello, everyone here, and thank you very much for listening to us. My name is Laura Laverdier, and I'm here representing our son, Andrew, and I'd like to just take a few minutes to speak with you about the personal maintenance allowance. I'm glad that that was brought up. Wish that a little bit more time could have been spent on that. I'm not surprised to hear that Virginia is the fourth lowest of the states that were looked at. Our son Andrew receives a Medicaid waiver to support his needs so that he can live and work meaningfully like his peers. But his Medicaid waiver supports preclude him from doing so. Because of the waiver, he must reduce his work hours and his hourly rates. He's currently working at Green Springs Retirement Senior Living Center, and he has received glowing awards. Here's one of his awards that he received last year, written by the residents who say that Andrew is one of the finest working cafe people here. He is the one that identified the milk that was going bad and brought up the issue. His managers love him and would like for him to work there more, but they work with me to reduce his hours so that we can stay under the income cap imposed by the Medicaid waiver. We have had to reduce his hourly rates so that we can stay under the income cap imposed by the Medicaid waiver. This has led to great emotional turmoil for somebody who wants to work very hard, who gets glowing reviews, and yet is told he cannot work because of his Medicaid waiver. So the waiver that's supposed to provide supports for him to be able to have equal access and ability is precluding him from being able to do so. When I fill out the Social Security reports that say what sorts of accommodations does he get for work, his accommodations are Medicaid waiver accommodations to keep him underneath the income cap. I appreciate, Senator Favola, your report that you shared with me, the February 2021 report, the study of current personal maintenance allowance for waiver services. You focused on ability. Andrew has the ability. He cannot work to his ability because of the Medicaid income waiver cap. This commission is focused on helping our disabled Virginians. I thank you very much for your time and your effort, and I'm hopeful that we will continue to make some progress. I was hopeful to hear that other states have looked at different ways that they might be able to address this issue, and I hope that Virginia can do the same. Thank you very much for your time.
Thank you. We'll go to our virtual room and take speakers as they come forward.
Madam Chair, we have 5 people who raised their hand to speak. I am going to list your name. I would like you to realize, if you're in the Zoom room, that you would remain muted until it is your turn to speak. Please unmute yourself and speak. I'm going to list the names. Please pay attention to the names and know who you're speaking after. First is Bill Fertig, then it's Thomas Steffens, followed by Delegate Shin, and then it's Robin Ryan Arson, and then Doris Ray. Bill Fertig, if you can unmute and go ahead.
Thank you, and Chairwoman Senator Favola and the group, I have 2 comments, but I'd like to introduce myself first. I'm a resident of Virginia Beach, Virginia. I'm a recent retiree from United Spinal Association, where I worked 16 years in furthering, among many other things, person-centered language. So the first of the thing, and I'm also a manual wheelchair user full-time after an accident in 1999, so for over 23 years. As such, I'd like to make 2 comments, one on the nomenclature question and one on assisted suicide. So on the nomenclature, I think disability is the appropriate word, but we always stress, and I hope that it would be acceptable to the group, to utilize person-centered language as in a person living with a disability. This would be all-encompassing without being off-putting, both to the individuals and to organizations. So I would encourage highly the use of person for language, person living with a physical disability, or person living with a vision disability or impairment. So that concludes my comment there, to consider person first language. On the topic of assisted suicide, in my role for 16 years as director of the Spinal Cord Injury Resource Center nationally, we encountered not only the suicide issue, but we also encountered the medical bias towards people who have a significant disability, and the inclination, it was mentioned earlier here, that anonymously doctors prefer not to treat individuals living with this disability. That's absolutely the case in my personal circumstance, and I have been discriminated against because of my disability in many ways. But through the resource center that I mentioned that I headed for 16 years, we had cases where patients with very severe injuries, very severe spinal cord injuries, were looked upon by the medical community and community at large as not having quality of life or not being able to have quality of life. My previous life, I would not have considered that being a full-time wheelchair user was a little impediment to me having quality of life. It absolutely requires me to do things a little bit differently, but there isn't anywhere I have wanted to go that I haven't gone. There isn't anything that I wanted to do that I haven't done. So I would add on to the comments of the woman from the Center of Independent Living very briefly that we need to be very cautious about having issues of assisted suicide, have very liberal language for that. And we would formally request that the commission address directly on the agenda in the future meetings the topic of assisted suicide so that the disability committee can have the opportunity to add their voice to this very important topic. Thank you.
Thank you so much.
Thomas Steffens, please unmute and go ahead.
Madam Chair, distinguished members, good morning, and thank you for your fine work. I wish all of my fellow citizens could have seen this meeting this morning. It's quite fascinating. It's great stuff. My name is Tom Steffens. I'm a retired Navy Admiral, and I was blessed to spend 34 years as a Navy SEAL. And I come to you this morning on behalf of our disabled veterans and to shine a light on the crisis of suicide, both among veterans and certainly among our active duty, and the impact of the potential of legalizing suicide in our Commonwealth. I wouldn't inundate you with the horrific statistics. I'm sure you've seen so many of them, but just a few. Over 6,000 vets in our nation committed suicide last year, 6,000. And 350 active duty. That's more suicide deaths than combat deaths. And it's become the leading cause of death among active duty military. I personally have, encountered or been involved with 3 suicides, one of an EOD captain who served 30 years, one of a SEALs Silver Star winner from Mogadishu, who left his family in such tragic circumstances, and then a young, brand new Navy SEAL who committed suicide a few years ago. So it spans the age range and the experience range of them all. And I would be remiss if I did not mention that we have unprecedented efforts going on at the federal, state, Veterans Administration, and hundreds of nonprofits, the Semper Fi organization, the Navy SEAL Foundation, the Valor Network, and my favorite in Chesapeake here, the Mutts on a Mission, who provides all these wonderful service dogs that literally save lives. It's quite an interesting event. And the Commonwealth of Virginia, as you know, has exceptional programs for our veterans. And I mention all these to highlight that as a people, and certainly as a true Commonwealth, as a society, we are working so hard to prevent suicide. So when I hear the subject of legalizing assisted suicide, when it comes up, it strikes me as counter to all that we are doing as a society. And when I speak with these various veterans administrations, the AMVETS, the Team Red, White, and Blue, the VFW, the instant and universal response, especially from World War II, Korean and Vietnam vets, and even the Iraqi and Afghani vets, but certainly the older vets, they say, Admiral, what are we doing? What's wrong with us? Is this what we fought for? So besides our concern for fighting for every last breath, our vets, we truly fear that legalizing assisted suicide, that saying our public policy is that suicide is okay, will send a deadly message, particularly to the thousands of disabled vets who, both by their obvious war wounds and certainly disabled by the impact of those unseen wounds of traumatic brain injury and post-traumatic stress. Young men and women that I deal with on a weekly basis, that this concern will exacerbate the suicide situation. It's not just a gut feeling. We've do a lot by gut feeling, of course. But
I just
But,
have to say,
in-
could you conclude? You're going a little over your time.
I will. I'm sorry.
No problem.
There's 17 suicides per 100,000 in Virginia, 27 per 100,000 veterans. But in Oregon, where this has existed for 20 years, the number is 47 per 100,000. And I would urge you, as you work so hard, as Madam Chair, as you said, to enable the disabled to have full and complete lives, to reject any idea about legalizing suicide in Virginia.
Thank you so much for your comments.
Delegate Shin, if you can unmute and go ahead.
Thank you, and good morning, members of the Commission and Madam Chairwoman. I am glad to be here with you all virtually, and sorry I couldn't be there in person, but I'm also here to talk about HJ 85, which we've covered pretty in depth already, but I wanted to add a couple more thoughts to that. I first wanted to say I'm very excited to see the unanimous support to adopt legislation that would recommend adopting, medically needy spend downs for DD waiver recipients. But I wanted to make the distinction here between what HJ 85 would have tried to do, which was to look at what it would be necessary in order to allow DD waiver recipients to work and lead meaningful lives and give them the full dignity of not just employment, but also of community. Medically needy spend downs will be helpful, of course, but it would be particularly helpful and really, I think, most helpful if it creates space for earnable income as opposed to just lowering and decreasing copays. The intention of HJ 85 and the objective was never to just lower copays for DD waiver recipients and therefore increase the cost of share increase the share of the cost by the Commonwealth, but to really just look at how can we allow DD waiver recipients to be able to work while still being eligible for their waivers. There is one other thing I would also like to encourage the Commission to look at, which is the Medicaid Works program, and understand whether Medicaid Works is a program that is currently accessible to DD waiver recipients, and if not, how that might be a model that we can look towards to building out pathways for folks on DD or DD waiver recipients to be eligible to work. I don't want to see the original question of HJ 85, which again seeks to understand how do we allow DD waiver recipients to work and lead meaningful lives, to get lost in the question of how do we eliminate the current 14,000 people long wait list, right? Which is an urgent and pressing question that we must answer. But those are two issues that are being conflated, I feel, in these meetings, and I want to make sure that we are addressing them distinctly. And so I would ask that the Commission look at them as separate issues. Thank you for all of your work, and thank you.
Thank you, Delegate Shin, and for your dedication to this topic. I do think we understand the distinction. Okay, may we have our next speaker?
Robin Reinarson, unmute and go ahead.
Good morning, everyone. Thank you for allowing me to speak today. I'm Robin Reinierson, owner of Jake's Ice Cream. I am an employer of 21 young people with disabilities. I'm here to try to remove as many obstacles to having people be employed as possible. The income barrier is one thing. I'm just going to remind everybody that in January, the minimum wage goes up to $12 an hour. That's an 8.5% increase. And as a result of that, 7 of my 21 disabled staff will have to cut their work hours. Some of the people that are working for me have transportation tied to their having a job coach. Our group job coach pulled out of our shop the end of September, so since we spoke last, due to their inability to be able to hire and retain staff. Consequently, I've had to let go 2 people that were far too disabled for us to incorporate. We've had to do a buddy system. I've had to pay people to come in and be a job coach for the remaining 7 that were working with the group coach. So it's being able to work is more than just money and loss of benefits. It's also transportation. It's also job coaching. So I'd like for you to keep that in mind, and thank you for allowing me to speak today.
Thank you, Robin.
Doris Ray, if you can unmute and begin your testimony.
Good morning, Madam Chair and members of the Disability Commission. My name is Doris Ray, and I live in Fairfax County, Virginia, and work at the Independent Center of Northern Virginia, which is one of the 17 centers for independent run by and for people with disabilities. I come here today to ask for your help in addressing one of the two major barriers to people with disabilities living independently in the availability of long-term care supports and services like personal assistance services is important and vital to the ability to be able to live in the community. But in addition to that, the other pillar of independent living is access to accessible, affordable, and integrated housing in the community. There is a major barrier in the state of Virginia that we hope you will help us to address, and that is the lack of stock of accessible housing, fully accessible housing available to people with significant physical and other disabilities who need accessible design, and the thousands of adults, senior adults who have physical limitations. We want to be able to live and thrive in the community all of our lives. And accessible design should not be something that is disparaged or thought to be a matter of charity. It is a matter of right to be able to live and participate in the community. Therefore, the problem is 20% of people, 20 or more percent of the population nationally and in our state are persons with disabilities. And yet, nationally, there is only 1% of the housing stock that is fully accessible. We, in our code, our state building code, require that 2% of all multifamily housing, now I'm only talking about multifamily housing, be fully accessible going forward from about 2003, I believe, but I could be wrong on that date, but remember, it's not until this century that we have even started to think about accessible housing.
Doris, I will have to ask you to
However,
conclude. Your time is running out.
Okay. So what we need you to help us to do is get the state building code, or at least consider state raising the required percentage of fully accessible units going forward and set it at 10% of all multifamily units. And we ask you to address the issue of how single-family dwellings can be made fully accessible. I'll end by saying this month, October, is not only National Disability Employment Awareness Month, but it is in Virginia Disability History Month.
Doris, I'll have to ask you
celebrating
I will have to ask you to conclude.
achievements of people with disabilities, and we need to be able to live in the community. Thank you.
Thank you. Okay. Do we have one more speaker that's in? Okay. Please come forward.
Good morning. My name is Lee Ellis. I'm from Fairfax County, and I'm a parent of a child and lots of neighbors with disabilities. I commend your efforts to address the growing developmental disabilities waiver wait list, to use person-first language, and particularly terms like disabled and impairment rather than handicapped, to provide options such as pre-ETS and the new alternative hiring process, and in particular do outreach on those because I find that a lot of folks don't know about them. I encourage you to do that outreach, engage people with disabilities in the process, and support them for having fulfilling employment, independent living, and appropriate educational opportunities.
Thank you. Does that conclude our speaker lineup?
Madam Chair, there are no more speakers online.
Thank you. Okay, colleagues, I'm just going to make an announcement. It is my hope and expectation that at our November meeting, we will adopt a recommendation regarding the changing of nomenclature. So we will have a recommendation, I hope, put forth by staff and tweaked so we can use the person-centered language on removing handicapped to disabled. So anybody who has comments, the proposal staff gave us is up online. Please feel free to contact, you can contact me directly. I'm at District 31 at senate.virginia.gov if you have comments, and I will make sure that whatever I've given or whatever you send to me, I will send out to the commission members. The other thing in November, I would like to adopt a work plan on topics going forward for our 2023 year. So I will ask commission members to please give me your ideas on topics you would like us to study. We may be able to do an in-depth study on 3 or 4 topics. We may still be able to have presentations on other topics. So, but I would like your ideas, and I guess one very common theme that's come up has been how do we remove barriers to work for those on our disability waivers. So we'll look at that topic for sure. And we will not have a December meeting. So that concludes the announcements by the chair.
Madam Chairman.
Yes,
Yeah,
yes,
I would
Delegate
just say,
Orr.
as we're looking toward a potential work plan, we need to do so with caution, given that I suspect there will be legislation requesting us to look at some issues in the coming year. So we'll just need, we don't want to load it up, but 1 or 2 items and then have placekeepers for others coming.
Thank you, Chairman Orrick. I was hoping we could get to 3 items, but maybe we could get to 3. But that was a very, very astute comment, as always. Thank you. Are there any other announcements from commission members? Okay, hearing none, I'll entertain a motion to adjourn. Okay, I think all those in favor may consider this meeting adjourned, and those who are not in favor may talk to me.